Before I get underway and hand the mic over to Dr. Yarbrough and to Adam, however, we will have time towards the end of the call for questions and answers. And I'd ask that people please use the chat icon on your display to enter any questions that you may have, and we'll get through those in the order in which they come in. And we should have time for everybody's questions at the end of the call. I'll turn over the mic over to Adam and Dr. Yarbrough for further introductions and to share the presentation that they prepare for us today. And with that, gentlemen, take it away.
Thank you, David. Can you hear me okay?
Loud and clear.
All right, wonderful. Well, thank you all for joining today. I really appreciate the opportunity to speak to all of you about surgery in the age of computing and our perspective on how we think we can impact healthcare in your community. I'd also like to start off by saying thank you. Oftentimes, I don't think we slow down enough to thank you for the partnership with Samaritan Health over the years as we've built this really great program between staff and administration and the surgeons who've worked so hard using this technology to build something special. And we'll highlight several of those items here today. So with that, well, let's get started. How do we think about surgery today in the immediate future in the era of COVID-19? You know, you think about what's going on in your world in Corvallis and Albany and other markets with regard to this epidemic and pandemic. And right now you're prioritizing your personnel and materials and resources. You're postponing in many cases, or in some cases, elective surgeries. People are also trying to figure out ways to manage your PPE and make sure that you can balance providing the security of a place for people to come to have good care, but you can't also push off elective care so much that people are letting these complications and risk factors rise. So this is a challenge, I think, in healthcare that the hospitals are responding to right now, and they've been kind of pivoting in many ways and reverting to less effective treatments for those without COVID as a triage strategy. But what we think about, and I'm sure you do as well, that's not a long-term strategy and that's not a long-term plan. While there is light at the end of the tunnel with the vaccines, we still got to get through these next 6 months or so. How we've tried to address that for you in your hospital and communities is providing the right value that we can immediately. So we produced over 1 million face shields and sent them out to hospitals and health systems all across the country. We created and deployed health safety for our employees who interact in your operating, making sure that we're doing everything we can to make sure that you have the right technology, you have enough access, that your supply chains aren't disrupted, and making sure that we're being safe with our employees in your hospital systems. We're also providing customer relief. So we're providing credits and money back to the hospitals if their volume and utilization drops down. So service credits, for example, we're extending warranties. And we've also lowered the average cost per case by anywhere between 10 and 20%. Just, you know, that's something that was in the works for a very long time to try to lower the total cost. And we're really pleased to give that to you. And I think it just happened to time up with COVID-19. So I feel like that's something that we provided, and also providing flexible resources, loaners, and we're going to talk about that today, of technology to help you provide the highest quality care you can. So as it relates to robotic-assisted Da Vinci surgery, elective surgery doesn't mean optional. And I think, you know, all the providers on the call would agree with that. And I think that's where right now we're seeing some pretty big challenges in the healthcare system with regard to people who are putting off getting diagnosed, for example. We saw this in prostate cancer back in 2013 when a panel said that PSA testing wasn't necessarily needed for many patients, and what we end up seeing was people being diagnosed with prostate cancer later, but with much more serious disease and complications, and dramatically increased the complexity of those cases. We know that, for example, on things like hernias in your abdominal wall, if you leave those untreated, it doesn't make that problem better. In fact, it makes it worse, a much harder surgery to do. And the increased hernia size gets bigger with waiting. And then same thing with gallbladder disease. We know that 10 to 15% of gallbladders that are inflamed or need assistance immediately in treatment become acute and issues in your operating room and your ER, and we need to make sure those patients still get the care. They're not pushing that off until their gallbladder bursts, for example, and they become much sicker. So we're trying to make sure that we're balancing all of these things and the delays, and how do we maximize that? One of the things we know about diagnosing cancer, and if you look at this example here, new cancer diagnoses, for example, lung cancer, about 13% of all the new cancer cases diagnosed, but we see that it's 22% of all the deaths, and the 5-year survival rates are really low. But with, for example, prostate cancer, the survival rate is very good. And so what we're seeing at the beginning of COVID, as it started off in March, really, we saw that the amount of people having colonoscopies dropped by as much as 80% up through July. We saw the number of people getting lung biopsies and chest x-rays drop dramatically as the pulmonologists were dealing with this COVID-19 pandemic. And so we've got to make sure that people have access to these treatments and care. And we know that we've made progress through the innovation of technology and great surgeons and hospital programs in many of these areas, like breast cancer survival rates, 5 years, 91%, prostate cancer, 99%. But there are still opportunities for improvement and dramatically, right? Colon and rectal surgery, still only about a 65, 66% 5-year survival rate. Lung cancer, only 20%. So while it's improved since the 70s, it's not improved the way that we think. And we think this is a problem that technology combined with your great surgeons can solve. And I think it's also important to remember that it's not just cancer that we have to treat, it's that people getting back to their lives matters. You know, we don't want to have people have to head to a major market and travel to go have advanced technologies. You've been able to provide this in your community, and I applaud you for it. But getting people back to their normal lives, getting them out of the hospital faster is really essential, I think, to making sure that you're providing a comprehensive program. We know, for example, the complication rates. For example, I mentioned abdominal hernia repair, about 17% complication rates nationally. Rectal cancer, 36% complication rates. How Intuitive thinks about that is that's not good enough. And that's a problem I believe XI technology that you recently purchased can help you solve, that you didn't have access to necessarily before with the prior existing technology that you had in your hospital. And so we'll talk a little bit more about that today. But the other thing is the robot is a great equalizer. And so we know from the New England Journal in 2013 that laparoscopic bariatric surgeons, the bottom quartile, so the bottom 25% of bariatric surgeons account for 3 times the number of complications and 2 times the number of readmissions than the rest of their peer group. So surgical skill and approach to a procedure matters. Robotics allows your surgeons to sort of standardize things where everyone can provide a better minimally invasive approach. If a patient comes in to have a minimally invasive procedure, they can leave invasive procedure, and this is how we've really built our platform for you around the value that we can provide. So robotic surgery really significantly reduces the length of stay. If there was ever a time that matters more than right now, I don't know when. Hospital beds all over. For example, I live in Los Angeles. I was just notified yesterday that there are only 5 available ICU beds at all of UC San Diego. And they're expecting to be 120% of capacity all over the state of California by Christmas. So getting patients out of the hospital for whatever type of surgery they need is really important, and robotics does that well. Reducing complications and surgical site infections, readmissions, the things that add incremental cost to the system and healthcare, and reducing the amount of conversions, as I mentioned. If you come in for minimally invasive surgery, do you leave with minimally invasive surgery? That's where robotics can add a lot of value, and where your hospital is already doing a great job with that now. We can reduce the amount of time people spend in the hospital, and that improves their patient experience. The longer a patient stays in the hospital, the more likely they are to get an infection or to have just run-ins with other people, which lowers their satisfaction scores. being able to do things in a more outpatient way or without the use of narcotics, which is one of the fastest growing things that we see right now with robotic surgery, particularly for inguinal or groin hernias, where many patients now are not requiring any narcotics whatsoever post-surgery, which is incredible. We want to make sure that we're always aligned with lowering your total cost of care, as I mentioned along the spectrum before. And how do we provide a great experience for the care team, preserving their careers and minimizing workplace injuries? One of the things Dr. Yarbrough can talk to you about is the ability for him as a surgeon in the community to work on morbidly obese patients, but do it in a comfort of sitting down in an ergonomic manner and be able to operate on these patients that in some cases could weigh 500 or more pounds. That can be really hard on a surgeon's body, impacts the quality of the care that they deliver, but the robot allows them to sit next to the patient at a console and provide that surgical procedure, but in a really comfortable way. We can also look at the analytics and data to improve the outcomes and the quality across all of the surgeons in your hospitals. And we provide a robust amount of training so that anyone who ever operates in your hospital with our technology is provided the highest quality of training they can get. We'd always rather have them practice in a cadaver or a pig versus a real patient, and we provide the resources for your hospital in order to do that. So adoption of this technology is really driven by the value that we can create. And I just mentioned sort of how we think about value, but what's really most important is how your surgeons have adopted this technology and how they can provide the most value to the community. This is an example in this slide of how new technology across virtually everything is adopted. Think about plasma screen TVs or smartphones. You know, you start off with a few people who are early adopters at the front end. They see a vision, and everybody else kind of says, let me wait and see what this looks like before I fully jump in. And then you kind of get to that place with technology where, hey, if you're not using this, you're really way behind and missing a lot of value in the boat. And we see that and saw that in Corvallis. I highlighted here, Dr. Yarbrough trained in 2010. He was the second general surgeon to do robotic surgery in the state of Oregon. And through his epicenter that we had at Good Sam Corvallis, he was one of the leaders teaching surgeons from all across the country. People were flying in from the East Coast to Portland and then driving all the way down to come and watch him operate and have him instruct. He had a vision early on, and what you can see here in that blue line, when he trained, there was almost no robotic general surgery being done anywhere in the country. And if you follow that blue line and that slope all the way up, you can see, and it's continuing to rise and continues to grow at an accelerated rate, even on a larger and larger base. So Dr. Yarbrough clearly saw something, as well as your CEO at the time, Larry Mullins, saw some value in this technology back in 2010. They jumped on board and were able to really provide more minimally invasive care. Dr. Yarbrough, any thoughts about when you were jumping into this in 2010, what did you see and what were your thoughts about how this technology could help the community?
Yeah, thanks, Adam. My background, for those who may not know, I'm a general surgeon by training, and I did a fellowship in minimally invasive surgery. So that would be just standard laparoscopic surgery at that time, back in 2006. You can see 2006 isn't even on the slide yet. So that the robot for general surgery really wasn't on the radar when I was training. So I did everything laparoscopically, which if you know about those types of operations, it's basically like operating with chopsticks. And it's a very difficult surgery to perform technically, and also difficult on the surgeon. The patients had a lot less pain, but the surgeon, some of that pain, in an essence, transferred to the surgeon. And they started releasing a lot of studies that surgeons who did a fellowship like I did in minimally invasive laparoscopic surgery were having much higher disability rates, personal disability, from overuse injuries because of the laparoscopic techniques of the day, which are still prevalent in the day. So the types of surgeries I do as a general surgeon is amplified because I do the weight loss surgeries. And like Adam was saying, that amplifies the amount of difficulty on the surgeon to operate. So honestly, I was I won't be ashamed to say I was 38 years old in 2009 when I came to Samaritan. And then when Samaritan got a robot in 2010, I already had wrist pain. And I had seen surgeons only 3 and 4 years ahead of me already being on disability for getting overuse injury operations. And I was experiencing wrist pain in my late 30s operating. And I was 4 years out of my training at that point. So that made me really step back and say, I need to look at this robotic. I know none of my peers are looking at it, but I need to look at this because the urologists had been really successful. And some of the gynecologists as well had been successful. So that was really, honestly, it was my impetus was just to say, could this give me a better operative experience? And also, could it give my patients a better experience? And I was just so pleasantly surprised that it did. It did both of those things. We had to figure out how to do robotics in our patients because we really didn't have any mentors at that time. And then I was able to then mentor a lot of other surgeons along so they could offer it in their communities. But honestly, Adam, for me, that fourth aim of it used to be called the triple aim until we forgot about like wellness of staff and providers. That now it's a quadruple aim. That fourth piece was really one of the biggest drivers for me going into robotics. And honestly, a lot of my colleagues, they tell me when they begin doing robotics, they just feel better at the end of the day. Obviously, they don't have as much pain, and it helps the patients with a lot of the things you said, but it also helps us. And so that was one of my big drivers back then.
Well, yeah, thanks for being an innovator and adopter. And you can see that your hospital jumped on in a time when you really adopted this technology and helped provide a lot of value, again, not just to the community, but also to the entire state of Oregon, which I think is remarkable. So it's not just a technology, though, that's innovated and adopted in Oregon. For example, if you look at prostatectomies, done in the United States, 90% of all prostate cancer surgery is done robotically. I actually think the number is probably higher than that for the operable ones, but that also is true in the United Kingdom, Germany, Korea, Japan, virtually all the developed nations around the world. And kidney cancer, similar. Gynecologic cancer, very similar. All across the world, we see that robotic surgery isn't just a technology that's used in these procedures, it's actually become the standard of care. And that lets you know that this technology isn't going anywhere. In fact, if that chart I just showed you shows you the trajectory of kind of where this is headed. But it's not just the technology in and of itself. Putting the new XI robot at Good Sam in Corvallis is not alone going to help patients. It's the combination of the technology plus the people, the surgeons, the staff, the caregivers, everyone from peri-op and pre-op and everyone across the chain. That's what it takes to build a good program. So we think about this as a company is we want to make sure that we design the right technology for patients, not just skinny patients and not just big patients, but one technology for all your patients, whether they're coming in at midnight with an acute gallbladder or they're coming in for bariatric surgery and they're morbidly obese. The technology has to be able to serve all of the patients, and that's one of the really unique things that Intuitive does in our design. We also design the technology around the care team and around the surgeons and making sure that it's efficient and effective, because if it slows the surgery or the procedure down too much, that costs the hospital valuable operating room minutes. And then how do we provide hospital leadership with information and informatics that help them improve quality and safety and cost and reduce the cost? So we're employing all of those principles, and we'll share some more data about some of the outcomes and the impact that you have in your hospital a little bit later today. Currently, the design that we've created, we have a robot for pretty much every body. We've got a no-port system, which is natural orifice, and that is right now mostly in a use for diagnostic, and I'll cover that briefly in a minute. We've got a new single port technology, which is really cutting edge, largely used right now, mostly in large academic centers, but now getting out into the community. It's one incision, 2.5 centimeters, where you can go in with basically in the umbilicus and your belly button and go and operate, and basically there's no scar for many of these patients. Quite incredible. The multiport technology that you see here, the XI with 4 arms, where we can go do multi-quadrant surgery. We can tilt the bed during the case so that the surgeon can use ergonomics, and they can also use gravity to help them in that case. And then the dual console. This is the surgeon's console where the surgeon sits and operates in that room next to the patient, for those of you who haven't seen that before. And one of the things that we wanted to do to try to become good partners with your hospital is providing a loaner console for the time being in order to help you and make sure that you're able to train other surgeons. So think driver's ed. You know, there's a driver on the right-hand side of the car and a driver on the left-hand side of the car. In teaching surgery, the way that surgeons used to learn was in surgery. And that's not what anyone wants. As I mentioned before, we don't want people to practice in patients. So how can we get them to use simulation, and how do we get them to have kind of trainer wheels as you're learning? And that's going to be a valuable part of the program in Corvallis and hopefully Albany in the future. As I mentioned, it's not just the technology, though, and one of the things you all have done, and I applaud the entire staff, you guys have done a great job. Again, it's not the robot. You have to have all of the resources, training and support, efficiency programs, the clinical evidence that we're helping you, and you're collecting your own, making sure that we're providing. Dave mentioned we've got a spectacular team in Corvallis on the intuitive side to help take care of your team and make sure that you have an effective launch of this new robot, and helping you with the marketing and helping you get validation to make sure that it's not just great for patients, but that's economically responsible for the hospital as well, which is really important for us to have longevity. So where are we now? Well, one of the things that's really interesting is that we've gone from sort of the early adopter phase with robotic surgery to now we're in this operational and standardization phase. And what I mean by that is that if you think about the intervention of a supercomputer between a patient and a surgeon, do we think that that is more likely to be less or more in the future? And I think it's somewhat rhetorical. It's going to definitely be more. So in the future, you're going to see a Da Vinci type technology in every operating room. Much like today in your operating rooms, you have laparoscopic towers. You're going to have some sort of a digitally assisted or robotic assisted surgery platform in every operating room. And so we're seeing that play out with the standardization. This is the number of hospitals with 5 or more systems in an individual hospital. And you can see since 2017, really, it's sort of growing exponentially. And, many health systems are putting, 5, 6, Cedars-Sinai, one of the local hospitals here in Los Angeles, has one of each type of technology and has 9 robots in their hospital. You look at OHSU and hospitals like that, I think they have, Dave, like 5 or 6 systems in their hospital as well. And we see that standardizing not just in large academic hospitals, but in community hospitals as well. So we work with your hospital on collecting data because data is important, and showing published articles, which we have 21,000 peer-reviewed articles about robotic surgery. But in our opinion, what really matters is your data. Your data is your truth. And so if we get great outcomes in a cost-effective way in Corvallis and in Albany, for example, we know that you're going to be more inclined to want to do more robotic surgery. So it's in our best interest to do everything we can to figure out where you're at now and how do we get you to be as good as you could possibly be. So we can provide data to your hospital, like how much open surgery are we really doing? A lot of times when I talk to executives at hospitals, they think they're doing much more minimally invasive surgery than they're actually doing. And that's why sometimes their costs and their standardization, why their length of stay doesn't match what it should for minimally invasive surgery. Again, as I mentioned, people come in for a minimally invasive procedure, but they get converted to open in the middle of that case. That conversion rate adds a lot of cost to the case, but also, disappoints the patients as well. So what is my length of stay? What is the readmission rate? Is that improving? And how does the robot program compare to your laparoscopic program or your open program? And how do you standardize and make sure that if there are places to get better and improve, that we can do that? So data is powerful in that. And this is your data and your analysis and your truth. And then lastly, In this example, how do we scale best practices across all surgeon lines? Here's an example of 4 surgeons across the hospital in their surgical volume, but also the average length of stay for a certain type of procedure. And you can see that, you know, the Dr. 1247 has a significantly lower length of stay than some of the other ones. Maybe they have complicated complications or other things that are impacting that, but are there opportunities to help them all get better and standardize around that one surgeon? So in this example, if all of those other surgeons could just get to the same as Dr. 1247, that hospital would save about 400 bed days per year. Think about the impact of how that helps the hospital and what you can do with that. So again, clinically meaningful innovation is having the right tools and technologies, people and training, and that's what powers progress. So again, you kind of see along this line of adoption where the technology is today. It's not just a robot, it's stapling, it's advanced energy devices, it's fluorescent imaging that helps us identify critical structures and things like ischemic boundaries so that we can reduce the amount of leaks, for example, that happen in colorectal surgery, a very dangerous complication. Your surgeons now today, because of your investment, have access to all of this technology, and it's only going to continue to get better. We have about 90 clearances across all of the different countries in the world and in the United States. So this is the technology that you have today, this multiport XI. It's really designed to be the Swiss Army knife robotic platform. It's across a broad platform of patients that it's indicated for. Again, it has all of the tools that fit on it and work with it. And we can provide, again, this imaging and next generation imaging with being able to, for example, do 3D imaging overlaid inside the body, which is really exciting. Your surgeons could definitely share more with you about that. We have procedure simulation. I'll talk more about what that is, but the ability for surgeons to practice the patient, practice the surgical procedure, much like flight simulation. Again, we've got the single port technology that we provide that is a little bit earlier on in its adoption phase. And we've got this natural orifice system. And again, if you can think about going in with this fiber optic shaping sense technology, where we're going out into the most distal part of the lung to do effective biopsies, providing a much better diagnosis rate. We had talked about at the beginning here how lung cancer is a major problem with early diagnosis, something that we're focused on. This is a technology and a platform that will help with that. And if you think about this kind of technology, if you can go in natural orifices, where else could this technology go in the future? I'll let your mind wander and think about where you think we may be taking that along with great doctors in the future. So again, all of this data can also be, is going to be captured, and the video is captured, and it helps us learn. So how do we incorporate things that you may have heard buzzwords about, artificial intelligence and advanced learning platforms? How do we take this and machine learning and figure out how the best ways to do a certain surgical procedure? So for example, at the University of Southern California, one of the other 600 robotic programs I oversee, they did a study with some of this technology where they looked at their best surgical procedures and they tracked every motion and movement inside the body with the robot. And then they compared that in the electronic medical records and the exact things that were happening with other surgeons, maybe that weren't quite at the experience level. And what we found is that it actually has impact on the oncologic outcomes. So how do we teach them? How does the design of this technology in the future help surgeons know, hey, maybe I'm getting a little too close to a critical structure I can't see? And can the Da Vinci system alert them, give them a little warning, for example, and give them some insight into what they may not be able to see with their own eyes? Machine learning helps us with that. And as I mentioned, we can use this simulation just like a flight simulator, where if you see in the video, and I know there's problems sometimes with the video on these large broadcast calls, but what you're seeing here in this video, if you can see it, is a surgeon practicing the procedure of an inguinal hernia repair, picking their instruments right now, what instruments they would use, how they operate differently in the case. They can go through and figure out the best way to enter. They can figure out the best way you can practice complications if they hit into a bleeder, for example, into a vein or artery that they're not supposed to hit. It teaches them how to interact and practice so that you are more safe in surgery for the patients. And this is the technology that you have access, your surgeons have access to today. So we're really excited about that and how this can help everyone improve their speed and efficiency, but most importantly, patient safety. So again, we talked about the quadruple aim and how we're aligned with that. We talked about your data and your truth, and we're provided and committed to providing you data that helps you really track the quality of your program, the cost of your program, the efficiency, and how can we get better together. We grow when you grow. So if your robotics program is really successful, you're more inclined to want to reinvest. That's just the simple truth. If this doesn't provide you value, then you're not likely to reinvest. And we know that, and that's why we want you to work with us on getting to your own data. And then how, again, can we standardize this across the community? So what can you expect from us? A customer-focused approach to making sure that everything is around the patient. How do we first make sure that we're always thinking about the patient and how we can help them? We really want to make sure that we're providing you all the tools and resources and training so that you don't just sell or buy a robot from us, but that you build a great program. And that's what we're committed to in all of your communities. I'm going to turn it over to Dr. Yarbrough now to talk a little bit about the data in the hospital and share with you some insights from his perspective.
You know, before I do that, do you mind backing up a slide? I just want to expand. One of the things that I wanted to mention for this group is we actually have looked at bariatrics, our outcomes, and we've looked at sigmoid resections or low colon resections, and we have found in our own hospital and our own data benefit of robotic, particularly in the colorectal. We compared the open approach to the laparoscopic approach to the robotic approach, and we did find that value, including cost savings. I just think it's important to the group to kind of know that. I really want to point out before we move into the kind of the current state of Good Sam is the teaching component. I didn't mention that the last time I spoke as much. Adam spoke to it a little bit, but I just want to make sure this group understands, you know, we're training general surgery residents, as we all know, in our hospital. And with the dual console, we're able to actually train them robotically. And what we have found is that those skills actually translate to laparoscopic operating and open operating. And so we've found that we're actually better educators to the residents. And we were also very early adopters for training. Now OHSU is training their general surgery residents, but they've only really started training their residents in the last couple of years because our residents rotate at OHSU. And some of the robotic surgeons up there that were the attendings were learning, and our residents were helping them because they had trained and done so many cases in our program. And so obviously we're proud of that. But what the other final thing I want to point out is the dual console, that's unique, and that's really for training programs. And with the new robot that we just purchased, Adam may have mentioned it or glossed over it super fast. Intuitive actually is loaning us. We didn't have to pay for that second console in that simulator because we're training our residents, and that was really helpful to us to be able to upgrade our technology recently, and we use that for training our residents, and they're walking out of here the highest trained general surgery robotic really anywhere because of the case volume. So I just wanted to point that out for this group to know. The next slide, we did a deep dive about a month ago, or maybe 6 weeks ago, where we were looking at what are we doing with our system. with our robotic system. So what you see on here inside the box is the data that Intuitive supplied to us in the box. And what you'll see, it's pretty small on your screen, but each of those bars represents a quarter. It starts with Q1 of 2018, then Q2 of 18, and you see 2018, 2019, and then you see Q1 and Q2 of 2020 inside the box. And what the dashed line represents, the dashed line is the U.S. average cases per quarter per system in the United States from Intuitive data. In other words, so like in that very first box on the far left, you see that we did 104 cases in Q1 of 2018. The average number of cases for a system was 61. So each robot system averaged 61 cases. What we long story short, we were utilizing our robot got tired. We were using it so much. We're so far above average. We're squeezing that thing as hard as it can be squeezed. And when you look at more to the right of the screen, where you see Q1 and Q2 of 2020. A natural drop off because of COVID, but we were still well above average. And then in Q3 of 2020, when we were off of our COVID restrictions, we actually did more cases that quarter than had been done in our whole history. I don't have the average number of cases, but I assume it's still well above average. Do you mind advancing the slide? We did a deep dive of the most recent completed quarter to see, okay, who's doing these cases? Because we're really, honestly, surgeons are having trouble getting cases on the system because we're using it so frequently every day of the week. And what we found was that my service was doing, a little under half the cases. The other general surgeons from Good Sam were doing 17% of cases. Urology was doing 20% of cases. Our GYNs are not as high volume currently with the current milieu of who's practicing here. And then Albany surgeons coming over just to do robotic cases that don't normally operate at Good Sam, we're doing about 16% of our cases. And that was the breakdown for the most recent quarter. Mind advancing the slide? So this was my summary of that data, was that we're consistently far above average, but stagnant. If you add up 2018 and 2019, actually we did exactly 377 robotic cases both years in 2018 and 2019. And then we had our biggest quarter, like I mentioned, and part of that would be post-COVID, but actually a significant amount of that is the uptick in Albany-based cases in Corvallis. And when I say that the cases were stagnant, that's not because we're not growing. It's because we don't have time on one unit. In other words, we're maximizing our one unit so much that we can't grow, even though there's potential to grow. We're currently we're scheduling into February. Now, obviously with COVID, I hope we get to do all these cases we have in December and January, but we're scheduling in February robotic cases right now. That's how backed up we are. And the most of the time, once you get to about 80 cases a quarter, that's when it's time for a system to have a second unit. And we've known that for a long time from Intuitive data. I have one more slide here. When I put this slide together, so this isn't something for Good Sam necessarily, but I wanted the Albany folks to consider whether or not it's appropriate that they should invest in a robot. And where I was thinking about that was, first of all, they already have 5 trained surgeons that operate at Albany. They're already trained. And that's in addition to one other that's committed. And I've even heard of a second surgeon that's committed. And I've heard of another one they've hired that's robotic trained in the GYN. And so all these folks, they want to do cases here at Good Sam, and we're telling them no. We have another Good Sam surgeon that is a high volume surgeon. He wants to start robotics, and we're telling him no. There's no room on the robot for you to do that. So I've been suggesting Albany might consider investing in the technology, because our system, honestly, we're bursting at the seams on our one. But anyway, so I just wanted to point this out to this group, that this was the discussion we've been having the last few weeks, and and a lot of the folks on the call know this because you've been working with me in this process. But the clinicians, the surgeons, are so excited that we up. I mean, we can't tell you how thrilled we are. I mean, it was the differences in the XI, the current that we upgraded to from the previous generation, is actually quite dramatic. And where we see the biggest benefit, one thing that people don't often think about, it's easier to set up. We're seeing our operating times go way down because the new robot is so much easier for the room to set up and for it to get docked, that we're already thinking that we can get an additional case on in our day, in my practice, because of the improved efficiency. And it's that much faster to set up and break down. That's one thing. You don't have to. We had actually overcome a lot of the. I mean, it feels like a deficiency now, but the deficiencies of the last unit. There's been an evolution in the technology. The last unit was the natural step from the first unit, but it wasn't designed for complex cases that involved multiple quadrants of the abdomen. For instance, some of the procedures I do in bariatrics, definitely colorectal, some of the kidney operations. The previous system, I mean, we overcame some of those challenges because we were early adopters and we figured it out. But it is so much easier to operate with the new system because of the way it's built, and it's just it's night and day difference. So I just wanted to give everyone that update now that we've been using it. I guess we've been using it now a little over a month, and it's really making the difference that we hoped it would. And I just want to thank this group and those on the call, because I see some folks on the call that actually made that happen for us. And so I just really appreciate that on behalf of the surgeons that operate on it. All right, thanks, Adam.
Yeah, one thing also that we've evolved as a company over time, 20 years into robotics, the first prostate ever done was 20 years ago last week. And, really in soft tissue surgery, there's no other company, believe it or not, that is in this space for the most part. There's a couple of very small companies, but nobody of note. And the reason why, people ask me this all the time, is why is that? And I say, because robotic surgery is really difficult to create that's safe and effective every single case, every single moment of every case. But we know that technology continues to change and evolve. And I showed you a little bit about the platforms and how they'll evolve over time. One of the things we provided your hospital, based on the last experience that you had, is we wanted you to feel comfortable to know that you could upgrade the technology or buy technology, and know that if you decided later on when new platforms come available that you want to go into that, we provided your hospital technology obsolescence language in the contract. So that way you don't have to worry about if the next thing comes out after XI. You just know that you're going to be protected and taken care of in that case, and we'll work with you on that. And that's something that we didn't do, what was it, 7 years ago, I think, when we put the SI robot in. So I just wanted to let you know that's one of the other things we're trying to do to be much more customer focused. And then the last thing is, for us, the success of the program is more important than the amount of the capital outlay. And so we want to make sure that if there's a capital concern ever with getting you to solve that problem, what problem are you trying to solve in Albany? If there are surgeons and patients who would benefit from it, for example, and that offloads volume at Corvallis, or if Corvallis needs another system, we don't want money to be the reason why you don't get the technology. So that's where we'll get incredibly creative and do flexible arrangements with you that you probably wouldn't even imagine. And I'm not saying that to give you a sales pitch. I just want you to know how much we are willing to be flexible and work with the program. So thank you again for all that. With that, I turn it over to Dr. Yarbrough, and then questions and answers.
Yeah, so we do have a question here, and we may both be able to answer this because you may be able to answer the question from the engineering side. I think we can. I think we're done sharing. But so it says, how does it maintain its coordinates relative to the target in a patient, given huge variations of patient position, size, etc.? For example, does it use vision systems that are somehow coordinated with CAT scan data file? And that's a really, really good question. The from a clinical user perspective, it actually, you're partially right on. It does, the robot knows exactly where all the tips of the instruments are at all times. And now with this new version that we didn't have with the old version, part of the safety features is that we as surgeons have an indicator of where the tip is, because these instruments can actually be off screen. In other words, we're looking in the console, we're zoomed in, and the instrument tips may not be in our working field of view and vision. And so in the previous version, you just kind of had to hope that it didn't get poked into something, you know. It sounds terrible, doesn't it? But in the new system, there's actually visual indicators of where those tips are. Now, that's not correlated to any pre-op imaging or anything like that. It's coordinated more, from my perspective, it's coordinated more from how we have the arms put in. And so we put the robotic arms in a specific location on the body based on the operation we're doing, based on the target anatomy. Adam, do you have a more technical engineering answer?
It's a great example. It's a supercomputer, so it's measuring and evaluating everything. And so one of the technologies that we have is the ability, again, for this machine learning to kind of know where should the aorta be, right? This is the largest black box of data collection. It can learn that over time. And so some of that is a little forward looking. One of the technologies we're really excited about now, I showed you a little picture of, is where it's an overlay of the MRI image of a kidney with a tumor. And where the surgeon has that on their screen, they click a toggle and it brings up that 3D image right in their face, looking at the organ and looking at the MRI image to know where the tumor, for example, is, so they can go in and mark the boundary lines of that tumor and then begin their operation, knowing they don't have to take more of the kidney than they need. That technology, Iris, is FDA approved and available now, and it's on the XI and something that, you know, your urologist, for example, can use. So I think that's a good answer with regard to how it knows where the instruments are. If there are more context with regard to how we use this imaging to advance, please let us know as well.
So the next question is a summary of the special infrastructure requirements, and actually that's good news as well. The newer version of the robot, the XI, the one we have, has a close to similar but a little bit smaller footprint, and the most special feature of the entire robot is the actual, what we call the patient cart, the robot, the part that goes to the patient. Previously, there were 4 arms that came off the base like a tree that has branches, and now it's off a boom. So there's one arm, one arm that comes out, and then as a boom, there's the 4 working arms are off the I don't know what the technical name is, but off the one branch. You know, there's only one branch, like a boom. And that has made it where the infrastructure is a lot easier, because we used to have to pull the robot all around the body, park it and drive it in and park it in just the right spot. And if it wasn't right, the arms would collide, and we needed a huge footprint in the OR. I don't want to say we can put it in a tiny, tiny room, because that's not quite true, because it's not that much smaller, but because of the boom, it can rotate the arms at the patient's side. And so we actually didn't have to really upgrade our infrastructure. Now you have to have, the particular room where we had it we just replaced it. So we had all the elements. I can't think of any other infrastructure requirements. You need high-speed internet, but we all have that in our rooms. And I don't think there were any other infrastructure requirements. Now,
Nope.
the next question is a really good one. Are we better off to buy a second Da Vinci in Corvallis or Albany? And I want to answer that because this is, to me, this is not a sales thing. This is just sort of the local milieu. Robotic technology, in my mind, is going nowhere. In other words, as the outcomes get better and better, and the patient experience is better and better, and the surgeon experience is better and better, more surgeons want to use the technology. That's a given. So there's surgeons in Albany that want to use it, probably Lebanon even, and Good Sam. The different fields that use it, GYN, urology in general, the number of cases only goes up in time. We've seen that in our own experience. So the answer to your question is, even if you took off first of all, let me say, for an Albany surgeon to operate in Corvallis, it's actually a heavy lift. Number one, their practice is not in Corvallis. Number two, they don't have block time. And number three, on the learning curve, you've got to do a lot of cases to get good at robotics and to make it a part of your practice. For that reason, they've got to be extraordinarily dedicated because they don't have blocked time to get on the robot. So the surgeons that come over, and there's 3 that come over from Albany, they've got to be highly motivated, and they can't do near the volume that they would do if they had the robot in Albany. So number one, from an Albany perspective, I mean, they need a robot. I don't have privileges over there. I'm not, that's not for me. That they need a robot because they literally have 5 users already that can't get on in Corvallis. They need their own, and I guarantee every data would show they would do plenty of cases to support a robot. Now that's Albany. Even if you took away that 15% from last quarter of the Albany cases, that would be more than made up by all of us who can't get our cases on currently, and the additional surgeons that want to do robotics and can't because we don't have the bandwidth in Corvallis. So in the grand scheme of things, I think we're busy enough to have 2, and they're busy enough to have 1. That's what I think we would be a 3 robot system, but that would be my answer to that. And there are options. There are certain cases, it gets into the weeds now of, well, where would you put the second robot in Corvallis? And we have thoughts on that with potentially at our ASC and some other things, because there are some cases that are ambulatory and probably enough to run a robot system. But anyway, that's my. Adam, can you?
And we see that a lot.
Yeah.
Right? So we see a lot of impression? Yeah, we see a lot of hospitals looking at places like their HOPD or their ASC to do robotic surgery, to offload maybe some of the more low acuity cases, so that you maximize the main OR robot for the higher acuity cases, the complex cases. And so having a robot on all of those venues is definitely an option. We'd be glad also if you'd like to talk to other hospital systems or hospitals who are similar to your makeup and how they've approached this problem. I think you're right, Dr. Yarbrough. It's definitely the demand is only going to expand, and the need for more access with more utilization and touches. The speed improves, so we can do more cases per day, and ultimately, you mentioned you're booking in February. I would imagine that's not always ideal for patients to want to wait through 2 or 3 months for their procedure to be done. And at times, I know in markets like Corvallis and other places, sometimes patients want to then go see, well, what if I went to Portland? What if I go to Eugene? Is there easier access there? And so one of the things I see across the country is this concern of out-migration from mid markets to major markets, because people think they can get something different that they can't get maybe in Albany. I don't know how much that's tracked by the board and foundation and the surgeons and staff, but that's something I would definitely look at, like how many people are seeking to get their care in other markets. We could also work with you on that data if you don't have that, but that's a factor I think that should be weighed in, because most of the patients who seek choice have good insurance. And from a financial perspective, that just makes logical sense, right? But those are the ones you definitely don't want to lose out of the community.
The next question is, first part's a technical part. How much data does the robot collect each case? Is it 1 terabyte, 2 terabytes?
Oh, geez. It's a ton. I don't know the exact specifics, and I think it depends on the length of the case. But the surgeries can be recorded and downloaded. So, and that's one of the technologies we're also working on, is the integration with EMR, with some special technology that we have, where, you know, that can be integrated. The whole procedure can be uploaded into the medical record, so that you can go back over time and provide the referring doctor some visual images and things like that. But the amount in terabytes, I'm not exactly sure. I could get an engineer to answer that question. So Dave Kelso, if you can follow up with me on that, we'll get an answer to that.
And then the second part of that is, how is that useful to improve patient care? And I think you partially answered it. And, you know, and some of this is a little bit futuristic, on the futuristic side of getting, you know, if you have recordings, then you can evaluate them for improvements, because we don't watch each other operate. You know, I don't go to others' ORs and watch them operate. And the technology allows that much better. In fact, there's even crowdsourced programs that will evaluate, you know, efficiency of moves and things like that. And there is some data, and it was alluded to earlier, that those who are scored as the worst operators, quote unquote worst, meaning the lowest quartile, have higher complications. That's been demonstrated. And so that's definitely a way the technology can be leveraged.
Absolutely.
Yeah. And I think when it gets easier, it'll be more widespread. I think that was perfect timing.
Yes, thank you so much. We appreciate it. So I want, on behalf of the Good Samaritan Hospital Foundation, I want to thank you, Adam and David and Jason from Intuitive, and you, Dr. Yarbrough from Good Sam, for this great presentation. We really appreciate your time and effort putting this together. I just wanted to make an announcement that coming up in our last 3 Med Talks for 2020, it's going to feature our CEOs from Lebanon, Albany, and Corvallis. On Wednesday, 12/9 at 10 a.m. will be CEO Marty Cahill. On the Thursday, on the 10th, at noon will be CEO Dan Kateri, and then and on Friday, the December 11th at noon will be our CEO Laura Henham. So thank you again, everyone, for joining us and for all your support, and we hope to see you again at a future Med Talk.
Thank you for having us.
Thank you.